Hey guys, it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be discussing hyperprolactinemia, which is an increase in the hormone prolactin. This comes up in a couple ways on step 1, but before we dive into the different pathologies that can cause hyperprolactinemia, let's first talk about the regulation of prolactin secretion and prolactin's activity in normal physiology. So looking down at the bottom of your screen here, you can see that the hypothalamus is going to regulate prolactin's release by communicating with the anterior pituitary, usually through thyrotropin release hormone or a couple different other signals. When it communicates with the anterior pituitary, it can stimulate the anterior pituitary to release prolactin. Prolactin's job is to go to those mammary tissues and stimulate lactation or the creation of milk. It's not the secretion of milk. Remember, oxytocin is going to be responsible for our milk letdown effect, but prolactin, or as I always like to remember, prolactation, is going to stimulate lactation, stimulate that milk production. Another important thing to note on this diagram is that dopamine over here is going to be a very important inhibitor of prolactin release. So dopamine is going to send that negative signal and tell this pathway to shut down, stop the release of prolactin. So dopamine has a negative sign because it is our inhibitory molecule for this pathway. Okay, so we talked about prolactin, how it is going to stimulate milk production and also its positive feedback. So the lactotrophs are going to be the cells that release prolactin, and the more prolactin is in circulation, the more the lactotrophs are going to be stimulated to release more prolactin. So it's kind of this positive feedback pathway here. When prolactin levels are high, this is going to inhibit the release of gonadotropin releasing hormone, which is responsible for stimulating the release of FSH and LH from the anterior pituitary. So when prolactin levels are high and we have low gonadotropin releasing hormone, we are subsequently going to have lower levels of FSH and LH, which will lead to lower levels of estrogen and testosterone in circulation. And we call this hypogonadotropic hypogonadism. And we call it that because we don't have this gonadotropin releasing hormone, so it's hypogonadotropic, and then hypogonadism because our gonads are not working as well. We're not releasing the estrogen or testosterone that we normally would if our gonads were entirely functional. So those are the effects and the control of prolactin secretion. But what is going to lead to a hyperprolactinemia? Well, things that can stimulate the release of prolactin are things like primary hypothyroidism. So if you think back to the negative feedback loop in thyroid pathology, if we don't have enough T4 or T3, our end products in circulation, we're going to keep trying to stimulate this pathway through the release of TRH. TRH over here, as we already mentioned, is also going to stimulate the anterior pituitary to release prolactin in addition to thyroid stimulating hormones. So whenever we have hypothyroidism, because that pathway gets turned on in response to the lack of production of T4 and T3, a side effect of that is that we're also going to see increased prolactin production, and that's how we can lead to a hyperprolactinemia in that setting. Additionally, pregnancy can lead to a hyperprolactinemia. This is more of a natural physiologic response. It's very necessary that your body is going to need to produce more milk during pregnancy, so it's ready to feed that baby when it arrives. So you're going to see high levels of prolactin in pregnancy. And then due to that positive feedback, these high levels of prolactin will continue well into breastfeeding. Sleep and stress can cause prolactin levels to fluctuate. It can mess with a lot of your hormones. And then finally, dopamine antagonists can really cause these prolactin levels to soar. As we already mentioned, dopamine down here has a negative effect on the anterior pituitary, halting the release of prolactin. So when we don't have dopamine, we don't have this giant stop sign right here to stop the release of prolactin, then prolactin is released more freely, and the lack of dopamine or dopamine antagonists can subsequently lead to the stimulation of prolactin secretion. So all these things can lead to the stimulation of prolactin secretion. But on step 1, the pathology that I want you to be most aware of is a benign pituitary adenoma. This is usually what they're going to test you on in regards to hyperprolactinemia, and a benign pituitary adenoma is just an increase in the lactotrophs. So when you have more lactotrophs, they're going to secrete more prolactin, and that's how you are going to get the stimulation of prolactin secretion in the setting of a benign pituitary adenoma. There are a couple other pathologies that are less testable but can also lead to a hyperprolactinemia. So non-secreting pituitary adenomas, these are pituitary adenomas that maybe aren't made of lactotrophs. They're definitely not secreting a ton of prolactin, but they can compress the infundibular stalk, that communication center between the hypothalamus and the anterior pituitary. When they do that, they are going to decrease dopamine's ability to communicate and stop the lactotrophs from making more prolactin. And like we already talked about, if you take away that stop sign of dopamine, then we are going to have the lactotrophs producing prolactin uninhibited, and so our levels of prolactin will increase in that setting as well. And then finally, I want to talk about the dopamine antagonists. We mentioned dopamine antagonists up here. We're taking away the stop sign again. These are going to be things like risperidone, haloperidol, fluphenazine. A lot of these antipsychotic medications will have a side effect of decreasing dopamine levels and subsequently decreasing the inhibition of prolactin. And then metoclopramide is actually an anti-nausea medication, but because it is also a dopamine antagonist, it can also have the side effect of increasing prolactin levels as well. So those are all the ways that we can have a hyperprolactinemia. But what does a hyperprolactinemia lead to? Well, the first symptoms that I want to talk about, I want you to associate with this lack of gonadotropin releasing hormone, which has some downstream effects inhibiting the release of estrogen and testosterone. So if you don't have estrogen and you don't have testosterone, that can lead to things like in females, a lack of ovulation. Estrogen is very important for ovulation, vaginal atrophy. We'll talk a lot about how postmenopausal women might experience vaginal atrophy because of low estrogen levels, low infertility or amenorrhea in women. That should make sense to you because we just talked about the lack of ovulation and the lack of estrogen. And then in males, the lack of testosterone can lead to things like decreased spermatogenesis. And then in both groups, we might see things like osteoporosis, and that's because estrogen has this really protective effect on our bones. And if we have decreased estrogen in males or females, you could see osteoporosis result because we have less protection of our bones. Now, the next set of symptoms I want you to associate more with the normal effects of prolactin. So remember, increased prolactin leads to increased milk production, and that's going to lead to something called galactorrhea. It is nipple discharge that occurs when you are producing milk. Gynecomastia in men. So men don't usually have breast tissue, but when we have this hyperprolactinemia that is going to be stimulating your cells to produce more milk, and those cells are growing, it's going to produce more mammary tissue in men. Bitemporal hemianopia can also occur from hyperprolactinemia. So this will occur mostly when you have some sort of mass in the pituitary that sits in the sella turcica, so something like a benign pituitary adenoma. And as this mass grows, you can see that it is sitting right below the optic nerve. So when this mass grows and compresses the optic nerve, it is going to cause a very specific visual defect. This defect is known as bitemporal hemianopia, and it is going to be loss of bitemporal peripheral vision. And that bilateral hemianopia is also going to be a very good clue that you have something going wrong right at the optic chiasm, likely a mass there, in this case, a pituitary mass. How we diagnose the underlying pathology causing our hyperprolactinemia is through a prolactin level. So we want to make sure that prolactin is actually elevated, and we can call it a hyperprolactinemia. We also might measure a TSH. Remember, I said that primary hypothyroidism is one potential cause. T4 and T3 can also go into this workup. And then additionally, your imaging is going to be very important here. So a brain MRI with contrast will be able to show you if you have a pituitary mass, enlargement of the sella turcica, and that could show you if you had something like a benign pituitary adenoma or compression of the infundibular stalk. And then finally, your treatment of the hyperprolactinemia is going to depend on the cause. If we have something like a mass, like a benign pituitary adenoma, we might do surgical resection. If we can't completely resect the mass, or if there's a different underlying problem, we might use a dopamine agonist. So remember, we talked about how dopamine antagonists can cause hyperprolactinemia. So it should make sense to you that a dopamine agonist can help solve the problem. And these would be things like bromocriptine or cabergoline. Okay, so there's a lot of information. Let's quickly recap what we talked about in this video. So first, the normal effect of prolactin is going to be an increased production of milk. Prolactin also is going to decrease GnRH production, which in turn will lead to low levels of estrogen and low levels of testosterone. The release of prolactin is increased anytime we have something like a benign pituitary adenoma or compression of our infundibular stalk by a different mass. Additionally, dopamine antagonists, like all of these drugs, can lead to increased release of prolactin. And then our symptoms of hyperprolactinemia, we can usually divide up into decreased GnRH, so decreased estrogen and testosterone, leading to this cluster of symptoms, and then just the symptoms of growing breasts or increased lactation associated with the normal effects of prolactin. We can diagnose our hyperprolactinemia with our prolactin level, a workup for hypothyroidism, and then some imaging to see if we have a brain mass. And then depending on the cause of our hyperprolactinemia, we can either treat with surgery or with a dopamine agonist. Okay, but how would they ask you about this on a board style question? Well, on a board style question, they might ask you something like, a 65-year-old male with a history of bipolar disorder on risperidone presents for gynecomastia and peripheral vision loss. Brain MRI with contrast is seen on the slide, so right over here. The hormone most likely in excess in this patient is also responsible for which normal physiologic process in women? Okay, so we have our patient coming in. It's a male who is presenting with gynecomastia. This man also has bitemporal hemianopia. Our brain MRI, you can definitely see there's a giant mass here in the pituitary, might be a benign pituitary adenoma. And then the question asks us, the hormone that's in excess in our patient is also responsible for which normal physiologic process in women? Well, because you watched this video, you will know that prolactin is the hormone that is responsible for milk production in women. Oxytocin does the milk letdown effect, but prolactin does the actual milk production. So if you see any answer choice that contains milk production, that would most likely be correct on step 1, and you would get that right because you watched this video. Now I hope this was helpful, and I'll see you next time.